Good afternoon, everyone. Welcome to the MacLean Center's 43rd Annual Interdisciplinary Lecture Series. If you don't know the theme by this point in the year, I'm disappointed in you, but it is Advocacy in Healthcare and Medicine. Before I introduce Professor Milliken, I want to remind everyone that next Wednesday, May 7th, will be Charlene Garlarno from Harvard. She'll be joining us. So two Bostonites coming back to back. I think, if I recall, that's the last speaker in this year's series, but we do have the little pamphlets up in the back if you need them and a brochure on your way out. And as always, if you're not on the MacLean Center's list host, be on the MacLean Center's list host, talk to the folks in the back where we have not just advertisements for the annual lecture series, but other events that come out throughout the year. So today, though, we're delighted to welcome Professor Aimee Milliken. She is an associate professor of the practice at the Connell School of Nursing. She practiced as a critical care nurse for over a decade and spent 5 years as a clinical ethicist, including serving as the executive director of a high-volume ethics service at a large academic medical center in Boston. She received her PhD from Boston College, where her dissertation involved the development and psychometric validation of the ethical awareness scale. Some of our fellows may be using that. During her postdoctoral fellowship, she received funding to research trends in ethics consultation. She has taught, published, and presented nationally and internationally on the topics of nursing ethics and clinical ethics, and she is co-editor of the Clinical Ethics Handbook for Nurses, emphasizing context, communication, and collaboration. Professor Milliken, it's great to have you here. Everyone, please give her a warm welcome.
Thank you so much. It's great to be here. Am I projecting loudly enough? Okay. All right. Excellent. If I get too quiet, just like flag me down. So thank you so much for the invitation. It's really a pleasure to be here. And this is, I think, exciting and timely work to get to talk about with you all. I know you've had a diversity of viewpoints in this lecture series, which I think is really fantastic. And so I look forward to digging into this with you. I have slides, obviously, but I would love to save time at the end for discussion and conversation. So let's get started. There we go. Okay, so this is sort of the roadmap for what I'm going to do with you all for the next hour or so. I'm going to start by offering a definition. And what I'm going to define is this concept called professional advocacy that Dr. Pam Grace did a lot of work with in the early 2000s. And I'm going to talk about professional advocacy in the context of nursing practice, to talk about what advocacy looks like in nursing practice and sort of use that as an exemplar for talking about advocacy work in clinical ethics. I'm going to talk a little bit about the status of the conversation when we're thinking about advocacy in terms of clinical ethics consultation, some of the controversy around that. And then what I'll do is to make an argument in favor of ethicists working as advocates. And you can pressure test that argument when we get to conversation at the end. Then I'll talk a little bit about professional advocacy in clinical ethics, in healthcare more broadly, some of the examples of successes we've seen in this arena, and some of the contemporary challenges we're facing. And I'll offer a few ideas sort of for a path forward here. Sound good? Perfect. So to start, I think it's important to define terms. And I think advocacy, like ethics, is a term that you sort of intuitively know what it means, and you may have sort of a gut sense of what it is that you're talking about when you talk about advocacy, but it's a little bit more challenging to offer a definition. And certainly when we think about advocacy in the context of nursing practice, this becomes, when you ask nurses what they do, what's the most important thing you do for your patients? What is sort of like the bread and butter of your work? Nurses will talk about being an advocate. I'm a patient advocate. I speak up for my patients, which is wonderful and true. But the problem is there are many senses of the term advocacy. So am I advocating for the person in front of me? Am I advocating for the community that they come from? Am I advocating for myself as a professional? Right, so the concept can be vague, and there are questions around what's the scope and limits of that advocacy. Is it an obligation? Must we act as an advocate, or is it something that sort of is nice to do, great to do if you have the time, but not required? And as I said, what is the population that we're advocating for? Is it the point of care person in front of you? Is it their broader circle? Is it the entire population? When we talk about advocacy in nursing, we don't always offer a lot of clarity, excuse me, around these questions. So because of this problem, Pam Grace, who's a nurse and philosopher, it says that I'm muted. Do I need to undo that? No, we good? Good, okay. Did some work around this idea of patient advocacy versus professional advocacy. So what I want to offer here right now is Grace's definition of professional advocacy. And I'm going to distinguish that a little bit from patient advocacy. So when we're talking about professional advocacy in the context of nursing practice, we're talking about advocacy that commits nurses to an examination both of the immediate practice environment. So where am I working? What is the patient population that I care for? What are the challenges that come up in the context of that practice? And also the wider context in which nursing practice occurs. So I need to think about the environment of my unit, and I need to think about the environment of sort of the society in which I'm working. And Grace would argue that professional advocacy involves actions that stem from professional role objectives. So we can also think about these as ethical obligations. What does it mean to be a nurse? In a few minutes, I'm going to talk about what does it mean to be an ethicist? How do we fulfill those nursing goals? Who decides what nursing goals are, et cetera? But once we have sort of a sense of professional goals and objectives, our work to achieve those professional goals and objectives can be considered professional advocacy work. And importantly, this stands in contrast, it's related to, but it's distinct from individual patient advocacy. And that's when I have a sense of this patient needs this thing, and I'm going to work really hard to get this thing for that patient. That's related to the work that we do as nurses, potentially related to the work that we do as clinical ethicists, but that's different. That's a different type of advocacy from the professional advocacy that I'm describing here. Does that make sense to folks? Okay. And so we can look at nursing codes of ethics, and again, in a few minutes, I'm going to do this for the clinical ethics code of ethics as well, to think about where have we, as a profession of nursing, established our obligations related to advocacy. And importantly, do I have any nurses in the room? One nurse, all right. Important to know, even for the non-nurses, that the ANA Code of Ethics was just revised this year. It just came out in January of 2025. I was actually part of the revision writing panel. And advocacy was in the last edition. It's even more prominently featured in this present, the current edition, I think recognizing some of the contemporary challenges we're facing in healthcare and in society more broadly. So in provision 3, it states that the nurse establishes a trusting relationship and advocates for the rights, the health, and the safety of the recipients of nursing care. And so we might think about this as being more aligned with the patient advocacy lens, right? So I want to think about what's good care look like for my patient? What's the right thing to do for my patient? And how can I advocate for my patient to receive those goods? Provision 9, though, talks about nurses and their professional organizations working to enact and resource practices, policies, and legislation to promote social justice, to eliminate health inequities, and to facilitate human flourishing. And I would make the argument that advocacy in this sense is reflective of professional advocacy, as I've just described it. So we both have to act as advocates for the individual patient in front of us, but we also have to think more broadly about the environment in which care is provided and how we can improve that environment in the interest of good patient care. So using this framework, I want to take this idea and apply it to the work of ethicists and to clinical ethicists specifically. And it's important to understand that, and my guess is you've touched upon this in the context of this lecture series, this is a controversial proposition. The idea of an ethicist acting as an advocate is something that many folks doing the work of ethics, and particularly the work of clinical ethics, say is not a great idea. We often have framed the work of the bioethicist as being sort of the neutral mediator or the impartial facilitator who is there to gather information, to hear a variety of moral viewpoints, certainly to keep sort of guardrails up, right? There are moral guardrails that you want to make sure that the resolution doesn't pass. But I'm not coming in with a decision about a particular outcome that I want and advocating for that outcome. Otherwise, I might run the risk of not hearing or devaluing or sort of speaking over other viewpoints that may be important and ought to be weighed in our ethical analysis. And certainly if we come into, for example, a clinical ethics consult and I have a vast body of work that relates to my personal political perspectives about things, it could create concern for partiality in terms of the context of a clinical ethics consult, right? People could think that I'm coming in with a preconceived notion of how I want the case to resolve, even if I'm trying to bracket my own viewpoint. And so this perspective has been explicated in the literature over the years. I'm going to read you quotes from a couple of articles that are about a little over a decade old. So this is a piece from Rasmussen who says that the question of whether clinical ethics consultants may engage in patient advocacy in the course of consultation has not been addressed. Again, we're talking about patient advocacy here. But it highlights for the field that consultants' allegiances, the boundaries of appropriate professional practice must be better understood. I consider arguments for and against patient advocacy and clinical ethics consultation in this paper. And ultimately, she demonstrates that patient advocacy is permissible, but not central to the practice of ethics consultation. So she's making the argument that it's something we can do. It's not inconsistent with the way we ought to be acting as ethicists, but it's not central to our work. It's not sort of an essential component of the work that we do. And then a few years later, Brask and colleagues touch upon this issue in two, and they further problematize the concept of ethicist as advocate, ultimately saying opinion is divided as to whether patient advocacy inherently is in conflict with the other duties of the ethics consultant, especially that of impartial mediator. So again, this concern of if I'm coming in with an agenda, people might think that I'm trying to apply my agenda to the situation in front of me. And in this article, they assert that patient advocacy is not inherently inconsistent with the function of the ethics consultant and the clinical ethics consultation process. So again, both authors here arguing that it might be related to the work that we do. There are potential concerns around it, but it certainly is not an obligation. So in the same way that I looked at the nursing goals and nursing codes of ethics, what we're going to do now is to look at the goals of clinical ethics consultation as outlined by ASBH and our professional bodies, and to look at the ASBH Code of Ethics for clinical ethics consultants and sort of see what we can glean from these professional viewpoints in terms of answering this question. So ASBH describes the goal of ethics consultation being to improve the quality of healthcare through the identification, analysis, and resolution of ethical questions or concerns. So my job is to pick up on an ethics question, help to identify a range of potential options, analyze the range of options, and make a recommendation about what to do. And in this work, for those of us doing work in clinical ethics, which I think is probably a lot of people in this room, we address a wide range of issues. But ultimately, the types of questions we're asking generally fall into the sorts of categories of questions that are about what's the right thing to do for this patient, or what does good care look like for this particular patient in front of us. And the mechanism by which we achieve this is called ethics facilitation. And so this is the approach to clinical ethics consultation that is endorsed by ASBH, where we're trying to identify and analyze the nature of the value uncertainty. So there's a conflict It's a value-laden conflict. In the context of an ethics consult, I'm trying to figure out what are the relevant values at stake, where are those values coming into conflict, and how can we sort of charter a path forward that is intrudes minimally on the sets of values that are coming into conflict here. And my job as the ethicist is to help facilitate the building of a principled resolution. So what should we do here, and why should we do it? How am I going to justify that recommendation? And so there's a couple potential approaches to ethics consultation. On one end of the spectrum, we may operate under sort of the pure consensus approach, which is there are no moral guardrails. My job is to come in and have everyone talk about the problem and agree about a solution. And we all feel happy and good about it because we're all on the same page. But potentially there could be problems about how ethically robust that solution is. Everyone agrees, but there could be potential ethical challenges there. On the other end of the spectrum, we could take a more authoritarian approach to ethics consultation, where the consultant comes in as the decision maker. And so I don't necessarily need to talk to any of the stakeholders because I have a sense of what is right. I know the ethical principles, I know the ethical frameworks, and I'm going to tell this team what to do. And of course, that is potentially very quick, right? It saves time. But as I mentioned earlier, it could potentially trample on important perspectives and viewpoints that ought to be heard and ought to be considered. So ethics facilitation falls somewhere in the middle here. And as I said, this is the ASBH standard, where I need to understand the viewpoints and the perspectives of all of the moral stakeholders. And I also need to have some ethical guide rails so that we're operating in a space of making sure that the recommendation I'm making is coherent with law, coherent with ethical principle. If there's precedent to turn to, we can look at the way similar decisions have been made in the past. I also want to achieve consensus as much as I possibly can. But what we know about a lot of these really tough ethics cases is that you're often choosing the least bad recommendation from a set of bad possibilities, right? So consensus isn't always possible if you're trying to make sure that what you're doing is the most ethically robust solution. So then we can think about what are the ethical obligations of the healthcare ethics consultant. We've talked about what our goals are, our approach to achieving those goals, but what does our code of ethics say about what we do and the role that advocacy work might play? And so this comes from the 2014 version of the Code of Ethics for clinical ethics consultation. And I'm not going to read all of these, but I want to draw your attention to number 7. And number 7 calls for clinical ethicists to promote just healthcare within clinical ethics consultation. And we can dive into this provision a little bit more deeply. And within provision 7, the document says that healthcare ethics consultants should work with other healthcare professionals to reduce disparities, discrimination, and inequities when providing consultation. Consultants have a responsibility to identify and include relevant voices in the discourse, particularly marginalized voices. And when possible, consultants should identify systemic issues constraining fair outcomes in clinical ethics consultation and bring these issues to the attention of individuals or groups in a position to address them. And so I would argue that each of these are examples of professional advocacy. I think each of these are ways that the clinical ethicist can think about the way the structures, the environment of care that we work within influences health and attend to those issues with the interest of improving healthcare for all of the recipients of healthcare that we encounter. So to sort of highlight this, clarify this a little bit further, this is the argument that I have made. And there's a 2024 paper about this that I've written if people are interested in doing a little bit of a deeper dive. But my argument is that despite the controversy that exists in the field, I would argue that the goals of the clinical ethicist, the goals of the healthcare clinical ethics consultant, and the obligations of the clinical ethics consultant are compatible with the role of professional advocate as defined by Grace. So if we think about that idea of professional advocacy, working to achieve the goals of the profession, sort of at a broader level, if we take Grace's argument and apply it to the obligations of the clinical ethics consultant, I think those are parallel. I think they're compatible. And further, I think that there's growing attention in the post-COVID world to existing inequities within our system. I think certainly COVID highlighted, put a magnifying glass on inequities that have been present for a very, very long time. And I think we're starting to see, with challenge, a little bit more attention to identifying and addressing those inequities. Importantly, these inequities are often the source of ethical conflict that we see as clinical ethicists. So the problems we're seeing at the point of care, the problems we're seeing when we get called for an ethics consult, typically are, if you look upstream, the result of issues within our system, inequities within our system. So in order to address the root cause of these issues, the ethicist must advocate for change at the system level in the interest of better outcomes for patients and better working environments for clinicians. And I'd argue that it's insufficient for us just to identify those sources of conflict. I think that we also have a parallel obligation to work to address them. So we can turn to some very, very recent work, so within the past couple of months, touching upon this question. And I'm going to talk in a few minutes about sort of the contemporary political climate we find ourselves in and how that influences this work, because I think that can be profoundly impactful in the way we approach answering these questions. So Wolf, in a JAMA piece from, I think, January of 2025, it sort of is looking at if we are going to communicate perspectives about policy issues, if we're going to work to advocate for change, we need to understand what are the parameters of that work? What are the boundaries of that work that we need to sort of make sure we're situating ourselves within? And he says, the scientific community is expected to respect diverse viewpoints, but in the final analysis, all share a professional responsibility to oppose policies that threaten the health of patients or the population. And so he argues that we need to draw a line when the science is clear that a policy will increase the risk of disease, complications, or premature death. So some of the examples he gives here have to do with vaccination, particularly pediatric vaccination, insurance coverage through the Affordable Care Act and Medicaid expansion, and identifying and addressing social determinants of health. So he makes the argument that we have robust bodies of data that substantiate the need to address these issues. And therefore, in the scientific community, we ought to advocate for work that furthers addressing these problems. And that, how many of you have seen this, like just, I think came out in the last week or two in the American Journal of Bioethics? So this is really interesting, particularly in the context of this lecture series. This is a piece by Passia and colleagues where they were interested in understanding the way bioethicists think about social justice and advocacy work. And so they were able to survey 355 bioethicists across the US and Canada. And what they found was nearly 3/4, so almost 75% of respondents indicated that they believe a key aim of bioethics should be to advance social justice and directly impact society. And if you sort of dig into the data a little bit more, some of the particular questions they ask relate specifically to advocacy work. And there's sort of overwhelming statistical majority in those instances of support for this work. Interestingly, and I think this is a related but slightly distinct point, there were mixed perceptions about institutional support for this work. So although people felt as though it was sort of part and parcel to the work that we do as bioethicists, their sense of how much their institutions supported them in doing that work was mixed. Another interesting tidbit is that younger bioethicists were more likely to endorse this viewpoint, and older bioethicists were less likely to endorse this viewpoint. So if we think about professional advocacy, I always think it's helpful to offer a couple of examples. And so these are examples of what I would define as professional advocacy work that was successful or resulted in change. And I think we can look to the crisis standards of care public pushback as an example of this. And so for those of you who were working in ethics or working in healthcare or just living in the United States in 2020, as initial crisis standards of care algorithms were sort of published and launched in the anticipation of entering resource scarcity as a function of how many patients were being admitted to the hospitals with COVID. There was a massive public pushback and public backlash from bioethicists, from members of vulnerable communities, particularly the disability community, from scholars sort of working in the health equity space, arguing that the algorithms as initially designed served to disproportionately impact communities that were already being disproportionately impacted by COVID. So we were sort of doubly punishing our most vulnerable communities. Should we enact crisis standards of care protocols as they were initially designed, particularly when it comes to considerations like the categorical exclusion criteria, which I'm not going to get into in a ton of detail, just to say that patients who had chronic illness or pre-existing conditions were deprioritized within these frameworks. And we know that patients with chronic illness and many of these comorbid conditions also came from communities that were highly impacted by COVID. So huge amount of public pushback, lots of conversation both in social media and in the academic literature that resulted in change. And Doug White in particular spent a lot of time thinking about, okay, how can we revise these algorithms to be more equitable? How can we revise these algorithms to make sure that we're attentive to the needs of some of these vulnerable communities? And I would not say that there's consensus around how we do this, but opening up the conversation created space for some of this change and this dialogue to occur. And I think we see some very contemporary examples, even in the past couple of months, of institutions acting as professional advocates sort of in the interest of health, of continuing to provide the status quo in healthcare. So examples of this would include legal challenges to executive orders challenging public health funding, some of the legal challenges to NIH cuts or the indirect cost limits that I know we have all spent a lot of time thinking about, talking about, cuts to LGBTQ plus and HIV services, USAID, right? I think looking at institutions who have taken positions, potentially offered legal challenge, those are examples of ethical leadership, which I would also consider to be advocacy, to make sure that sort of at the point of care, the boots on the ground people are still able to take care of patients. Now, all of this to say, and when I first started thinking about this work and publishing about this work, the context was very different than the context that we're in now. And I think there are formidable barriers to consider when we're thinking about professional advocacy work. In the immediate 2022-2023 sort of post-COVID time when people were just sort of re-entering the world, we did see some of this pushback. And so what I have on the right-hand side here are examples of protests that actually happened like right outside my office window when I was at the Brigham. We had clinicians who were looking at the way trends in admissions to the cardiology service. There was a sense that more white patients were being admitted to our cardiology service with heart-related issues, and more Black patients were being admitted to our general medicine service with heart-related issues. And so they wanted to look at whether those patterns were borne out in the data, which they were, and then they wanted to offer interventions to pay attention to race when we were making admission decisions. And that research gained some public attention, which resulted in, we had some protests outside of our hospital claiming that the research was racist, calling the researchers anti-white. Around the same time, the Brigham is right up the street from Boston Children's Hospital. Their gender-affirming care clinic received a lot of negative attention in the media. They had a number of bomb threats called in. So I raised these just to highlight the fact that even before 2025, there were potential challenges to some of this advocacy work. Interestingly, when I talk with, I teach in the Graduate School of Nursing at Boston College, this doesn't tend to come up as a reason people say they don't want to engage in policy work or they don't want to engage in advocacy work. What tends to come up is I don't have time. Like I work a lot. I'm working 50, 60 hours a week. I don't have time to go like lobby on Capitol Hill. The best I can do is vote. And so I think this time commitment or the perception of time commitment becomes a huge barrier. Public pushback, I think these are some of the examples of that. There can be professional consequences and organizational hesitation. One of the examples we saw during 2020 was clinicians who spoke up about inadequate PPE. There were clinicians that lost their jobs for going to the media and talking about those issues. So I think there's a vulnerability that can be created for speaking up about some of these questions. Certainly threats to well-being, as I think these examples highlight. And then again, in clinical ethics consultation, there can be the appearance of partiality, which can potentially be a problem when we're thinking about a clinical ethics consultation for a particular patient. And then certainly 2025 has given rise to additional barriers. So threats to institutional funding, threats to the academic freedom, which I think historically has been protective in this regard, that clinical ethicists haven't always been protected by academic freedom, particularly if you're working within the hospital setting. If you were working at a university, you may have been a little bit more protected. I think that is less the case in the present day. And then certainly the targeting of individuals, threats to individual liberties, that sort of thing that we sort of have seen borne out in the media. And so I think in this context, when there is risk to an individual, part of what we need to do is to lean on organizations. And so in response to the protests that I showed 2 slides ago, here's an example of the Mass Coalition for Health Equity published an open letter in support of the researchers doing that work. This was, I think there were over 300 signatories on this letter coming out in support of the work being done by the researchers who were targeted. And in response to the bomb threat seen at Boston Children's Hospital, they published a statement in which hospital leadership said Boston Children's is proud to be a home of the first pediatric and adolescent transgender care program in the United States. So again, sort of using the collective power of the organization to support the important work. So as I've alluded to, I think leveraging sort of collective action and institutional power when we do belong to organizations that wield significant power can help enact some of the professional goals to help ensure that we can provide the status quo of healthcare and improve the status quo of healthcare without necessarily subjecting individuals to risk when that risk feels untenable. And so these are just a couple of examples of ethical leadership that we've seen in the past few months. So given the argument that I've made, given the examples of successes and barriers that I've offered, how can we think about engaging in professional advocacy work and what might be helpful sort of reframes that we could offer to make this work a little bit easier? So as I've mentioned, for some, collective action through professional organizations might be safest for individuals who feel particularly at risk within their organizations or as a function of the type of advocacy work that they do. We've touched on academic freedom. And then I think the other thing I want to mention that I haven't necessarily raised is this idea of sort of workarounds or behind the scenes activity. And especially within the context of patient care, we do a lot of this. Nurses are creating workarounds for our patients all the time to get the care that they need. And that doesn't necessarily need to get published anywhere. You're creating change. It doesn't necessarily need to be sort of put on the front page of the paper. I also think it's helpful to sort of reconceptualize what it is that we mean when we're talking about advocacy. Yes, it is things like running for office, but not all of us feel called to that. So we should if we want to, but that's not going to float everybody's boat. So I also think we can think about many of our scholarly outputs as being works of professional advocacy. So what we publish, where we publish, the types of things we write about, research and dissemination, the types of things that we try to get funded, the places where we publish the outputs of our research. I think when we're thinking about scholarship and disseminating scholarship, it's also really important to think about the accessibility of those research outputs. We publish in academic journals that other academics read, but does that work get filtered down to the general public and to the patients that we care for? Not as much. So how can we think about increasing the accessibility of that work? I think other things like social media presence, I think some clinicians use that very effectively as a way to create concern and move questions forward in the realm of professional advocacy, and then certainly voting. I also think this framing is consistent with a preventive ethics approach. And so we know that preventive ethics involves sort of identifying recurring sources of ethical conflict and then working to address them. And so when I'm thinking about professional advocacy as a clinical ethicist, I'm thinking about, well, what are the types of cases I'm seeing over and over and over again? What are the types of vexing problems that keep coming across my beeper? And how can I think a little bit further upstream about what's contributing to those problems and work to address them? And that upstream approach to that work is professional advocacy. And Faro and colleagues would say that if we wait until the conflict arises, till we actually get the page for the ethics consult, it makes the resolution of ethical quandaries more difficult, and our traditional reactive versus proactive approach to ethics concern accepts too readily the recurrence of ethical problems. And I know when I was full-time working as a clinical ethicist, it became very frustrating to me, the sorts of questions that came up again and again and again that felt like they had an easy fix that I just was not able to reach. So things like discharge planning quandaries when we didn't have beds in the community, right? Like that sort of thing, where it's like, I don't actually have any control over whether or not there are beds available. But somebody somewhere does. And how can we think about addressing that question? And the other thing I want to really highlight is the fact that thinking about engaging in professional advocacy work as an ethicist is very consistent with other bioethics lenses. So if we look at in the work of Black bioethics, Faith Fletcher and Keisha Ray, disability ethics, Joel Michael Reynolds, feminist ethics, Georgina Morley, social bioethics framing, all of these are approaches to identifying and addressing ethical issues that pay attention to systems and power dynamics within systems and how we sort of name that power and attend to that power and address problems in a way that keeps that power in mind. And so my argument would be that acting as a professional advocate in the sort of way that I've levied the argument here is not new. It's very consistent with the way many people have been thinking about bioethics for a long time. And that's it. I'd love to have questions and conversation now.